Part 1, Basic Principles, Chapter Metabolic Response to Injury. Part 3, Metabolic Changes after surgery and trauma. The catabolic phase begins at a time of injury and lasts for about approximately 24 to 48 hours, and it has been attenuated by proper resuscitation and characterized by hypovolemia, decreased basal metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. The predominant hormones regulating the catabolic phase are catecholamines, cortisols, and aldosterone, following activation of renin-angiotensin system. The magnitude of this neuroendocrine response depends on the degree of tissue damage, blood loss, and the stimulation of somatic afferent nerves at the site of injury. The main physiological role of catabolic phase is to conserve both circulating volume and energy stores for later recovery and repair. Following resuscitation, the catabolic phase involves the hypermetabolic flow phase, which corresponds to SIRS. This phase involves metabolism of body energy stores for recovery and repair and subsequent replacement of lost and damaged tissue. It is characterized by tissue edema from vasodilatation and increased capillary leakage, increased basal metabolic rate, hypermetabolism, increased cardiac output, and raised body temperature. Leukocytosis, increased oxygen consumption, and increased gluconeogenesis. During the catabolic phase, the increased production of counter-regulatory hormones, including catecholamines, cortisol, and glucagon, and inflammatory cytokines such as IL-1, 6, and TNF alpha, results in significant fat and protein metabolism, leading to significant weight loss and increased urinary nitrogen excretion. During shock, insulin levels do not go rise as expected to combat the hyperglycemia that occurs in response to stress hormone release, and plasma insulin can even fall after severe injury. Within few days, insulin production is increased and is associated with significant insulin resistance, and therefore injured patients often exhibit poor glycemic control. Importantly, the combination of pronounced or prolonged catabolism in association with insulin resistance places patients within this phase at an increased rate of septic and other complications. Obviously, the development of complication will further aggravate the neuroendocrine and inflammatory stress response, thus creating a vicious catabolic cycle, and management of blood sugar level remains an important step. Purpose of neuroendocrine changes, summary box 1.7, following surgery or trauma. The constellation of neuroendocrine changes following surgery or trauma acts to provide essential substrates for survival from tissue breakdown. Postpone anabolism, optimize defense, host defense. These changes may be helpful in short term but may be harmful in long term, especially to injured or critically ill patient. The next topic is managing the catabolic stress response. There are several key elements that determine the extent of catabolism and thus govern the metabolic and nutritional care of this surgical patient. And it must be remembered that during the response to injury, not all tissues are catabolic. Indeed, the essence of coordinated response is to allow the body to prioritize limited resources away from the peripheral tissues such as muscle, adipose tissue, skin, and towards key viscera such as liver, immune system, and the wound. as in figure 1.3, that says during the metabolic response to injury, the body prioritizes protein metabolism away from the peripheral tissues and towards the key central tissues such as liver, immune system, and wounds. One of the main reasons why reutilization of amino acid derived from muscle proteolysis leads to net catabolism is the increased glutamine and alanine influx from muscle is derived in part from irreversible degradation of branched chain amino acids alanine and glutamine. Like you can see in this diagram, peripheral tissues such as muscle, fat, adipose tissue, and skin, they break down into amino acids, essentially glutamine and alanine, uh, to to key central tissues such as liver, immune system, and the wound itself. However, the damage to skeletal muscle can be catastrophic. Now, the next topic is hypermetabolism. The majority of the tissue trauma patients, except possibly those with extensive burn, in whom greater effect can be seen, demonstrate energy loss approximately 15 to 25%. 15 to 25% of energy loss can above predicted healthy resting values. The predominant cause appears to be complex interaction between the central control of metabolic rate and peripheral energy utilization. In particular, central thermodysregulation caused by pro-inflammatory cytokine cascade, increased symptomatic as increased sympathetic activity, abnormalities from wound circulation, ischemic area produce lactate, which must be metabolized by adenosine triphosphate, ATP consuming hepatic core cycle. Hyperemic areas cause an increase in cardiac output, an increased protein turnover, and nutritional support may all increase the patient energy expenditure. Theoretically, a patient energy expenditure could rise even higher than observed level following surgery or trauma. But several features of standard intensive care, including bed rest, paralysis, ventilation, and external temperature regulation, limit the hypermetabolic driving force for stress response. However, the skeletal muscle wasting experience by the patients with prolonged catabolism usually limits the volume of the metabolically active tissue. Alterations in skeletal muscle metabolism. Alterations in skeletal muscle metabolism. Muscle protein is continually synthesized and broken down with a turnover rate in the human of 1 to 2% per day. Under normal circumstances, synthesis equals breakdown and muscle bulk remains constant. A physiological stimuli that promote net muscle protein increase include feeding, especially extracellular amino acid concentration and exercise. And paradoxically, during exercise, skeletal muscle protein synthesis is depressed. But it increases again during rest and feeding. During the catabolic phase of the stress response, muscle wasting occurs as a result of an increase in muscle protein degradation by a enzymatic pathway coupled with a decrease in muscle protein synthesis. The major site of the protein loss is the peripheral skeletal muscle, but it also occurs in the respiratory muscle, predisposing to the patient to hyperventilation and chest infections, and in gut, reduces gut mortality. Cardiac muscle appears to be mostly spared. The predominant mechanism involved in the wasting of the skeletal muscle is the ATP dependent ubiquitin proteasome pathway, that is in figure 1.4, which says that intracellular effector mechanism involved in degrading the myofibrillin protein into free amino acids, the ubiquitin proteasome pathway It's a complex multi-step process in which ATP, adenosine triphosphate, E1, ubiquitin activating enzyme, E2, ubiquitin conjugating enzyme, E3, ubiquitin ligase acts. Now you can see the myofibrillar protein, with the help of caspases and cathepsins and calpains, are along with ATP under the influence of E1, that is ubiquitin activating enzyme, E2, that is ubiquitin conjugating enzyme, in E3, that is ubiquitin ligases. The protein then is ubiquitinated. After that, it forms a 26S proteasome, 19S, 20S, 19S. With ATP, then the substrate unfolding and proteolytic cleavage occur, which results in formation of oligopeptidase, and oligopeptidase is further converted to amino acids with the help of tripeptidyl peptidase, and ubiquitin from the ubiquitinated protein is released, and ubiquitin again forms react with the myofibrillar protein to form ubiquitinated protein with help of ATP and these enzymes. Now, under extreme condition of metabolism, for example, major sepsis, urinary nitrogen losses can reach up to 14 to 20 gram per day, and 14 to 20 gram per day of urinary nitrogen loss is equal to around 500 gram of skeletal muscle loss of 500 gram of skeletal muscle per day. And muscle catabolism cannot be inhibited fully by providing artificial nutritional support as long as the stress response continues. Hyperalimentation, that is excess feeding beyond requirements, was once in vogue to try and match the large losses, but it is not recognized that hyperalimentation response represents a metabolic stress in itself, and metabolic support should be at modest level to attenuate rather than replace energy and protein loss. Treating underlying sepsis adequately is fundamental to limiting protein catabolism. It is an essential part of effective nutritional support. This includes searching for and treating recurrent septic episodes in critically ill. Now, clinically, a patient with skeletal muscle wasting will experience weakness, fatigue, reduced functional ability, decreased ability of life, and increased risk of morbidity and mortality. In critically ill patients, muscle weakness may be further worsened by the development of critical illness myopathy, a multifactorial condition that is associated with impaired excitation contraction coupling. Now, summary 1.5 says that skeletal muscle wasting provides amino acids for metabolic support for central organ tissues. And so, mediated by a molecular level mainly by the activation of ubiquitin proteasome pathway. It is inevitable to some degree by but is prolonged by sepsis in particular, can result in immobility and contribute to prolonged recovery, poor healing, hypostatic pneumonia, and death if prolonged and excessive.